So thank you for having me this morning. I'm going to stand because I talk a lot with my hands and I just can't be contained in a chair. I work with PMC predominantly in primary care offices. And back when a lot of this controlled substance legislation was starting back end of 2017, a lot of my physicians had a lot of questions on what does this mean as providers? How are we going to continue prescribing these medications now that the government's really controlling everything we do? So I'm hoping by the end of this presentation you don't feel like that's the case where the government's really tying your hands, but really focusing on what we can do as providers to safely prescribe and have patients use these medications. So as we begin today, just a disclaimer that I am a pharmacist, so all the information in this presentation is purely educational. So let's get into what we'll be going over this morning. The bulk of my presentation will be focusing on the different legislation changes that did occur within the past year, as well as what is up and coming. And then I will spend part of the presentation just going through the Michigan Automated Prescription System, better known as MAPS, to make sure that everyone has a clear understanding of where that information is coming from and how to best utilize that tool in managing patients on controlled substances. So let's see kind of what changes happened in this past year. I think before we go into it, it's important to keep in mind what these legislation goals were. Again, it's not trying to dictate what you are able to do as providers or healthcare professionals, but looking to more as an overarching goal of public safety. So what can we do to ensure that we are safely using controlled substances and making sure that the right people are getting those controlled substances for a medical purpose, really trying to prevent the misuse and abuse of these controlled substances. So quite a few things have happened in the past year in relation to the prescribing of controlled substances. There were actually about 12 public acts that were approved by the Lieutenant Governor back in 2017. These are the ones that most pertain to you guys as providers and healthcare professionals. There was some added legislation regarding education in the schools, some different curriculum kind of initiatives, and some different policy regulations. So today I'll be focusing mainly on these public acts because these are the ones that are going to impact you the most in practice. As you can see with all of these acts, most of them are currently already effective with the exception of Public Act 247. They are working to finalize some of the wording on what that prescriber-patient relationship is going to be defined as, and so they're anticipating it will be effective at the end of March of 2019. In the coming slides, I will be going through what the public acts that are going to be most pertinent to you as prescribers. I will not be focusing on substance use disorder because that is a whole nother lecture for another time. But of note, Public Act 250 does require a patient who is treated for an opioid-related overdose to receive education on substance use disorder. And so I would encourage you, if you are have the chance of treating a patient with an overdose, that you are aware of the resources available for them to seek out substance use services. Also, Public Act 257 requires a MAPS report to be reviewed prior to prescribing or dispensing any medications for substance use, such as buprenorphine and methadone. If you weren't aware, these medications don't always pull up on the MAPS report if they're getting it from a substance use clinic. So it's good to know that if your patients are being treated for substance use, that someone is reviewing the MAPS to make sure they're not inappropriately getting medications. So in the next slides, I'll go through kind of the other acts to make sure you guys are at least aware of the minimum standards when it comes to what you have to do by the law to prescribe these medications. So the first being Public Act 246, and this is the act that requires patient consent prior to getting a prescription for an opioid medication. As I go through these acts, do note if I'm specifically saying opioid medication, I'm referring to opiates as a class of pain medication. So this is going to include your Schedule II products as well as your non-Schedule II products like codeine and tramadol, so those will all be lumped in one class. When I refer to controlled substances, that'll be referring to any medication scheduled 2 through 5. So just keep note as I'm going through on what kind of classes medication is going to be included in these laws. There were different mandates on what minor patients, so anyone under the age of 18, had to be informed of versus adults. But again, very similar of making sure the patient knows what the medication is, the risk of overdose, of using this medication with other CNS depressants such as alcohol or benzodiazepines. For adults, specifically looking at how to dispose of these medications, as well as what penalties if you were to divert those medications. So the state does provide a start talking consent form that providers are free to use. You can also make edits to it, but they would recommend you have an attorney look it over to make sure you're not doing any sort of copyright infringement. So that is available if you want to use it, or you're free to use any form that would meet these standards. With this law, it is important that the patient does sign and is part of the medical record, but by having that signature, you are stating that they are receiving this education in some way. So do make sure that you are either verbally or giving the patient some written education that does explain the risk of using these medications. Also, with the patient consent, it is required at the initial course of therapy. So know that if you're treating a patient chronically, you need consent at the start of therapy, but if you're consistently treating or continuously treating, you don't necessarily have to have that consent form signed at each visit. If the patient was stopped on the opioid medication and then took 6 months off and then restarted 6 months later, you would need a consent form again at that point. But as long as they're receiving continuous therapy, you just need consent at the initial prescription. The next public act is looking at the prescriber-patient relationship. This is the formal definition that was provided by the state, but they are working on further clarification on specifically what you do with covering physicians, if you are covering for a partner and need to prescribe.
Just going back to the other form, if they change prescriptions, if we switch the prescription, if we're on tramadol, for example, we move to morphine, is that something that we need to address with a new one, or is it just lumped in as one?
So with that, as long as it is still part of their therapy, per the state recommendations, they would not need a new consent form. It would depend on what your policy and how you felt about changing within that class. The only nuance with that is if you've been treating them prior to June of this year and then change their dose, you would need a consent form at that point. So again, it's going to be what's.
So you don't have to change what we have to do every year.
It's
from the beginning of
initial course of therapy of treatment. So it should be good at that initial when you first prescribe and should carry it out as long as you continue to prescribe and there aren't any sort of gaps or changes in therapy at that point, is how it is defined in the state. But again, it's whatever you guys deem as best practices for your office. So getting back to the patient-prescriber relationship, this is really targeting a lot of the drug mills that were happening throughout the state where you could go to a provider, pay $100 and walk out with a script for Norco without seeing anybody. So again, as long as you are treating the patient, this probably isn't going to really impact what you're doing. Making sure you're doing a full assessment of the patient prior to prescribing them any controlled substance, as well as documenting and having record of seeing those patients. Again, there's going to be further clarification coming within the coming months to more specifically define situations for emergency prescribing use if you're covering for another physician, as well as with some of the nurse practitioners and PAs, what that looks like when you have a supervising physician who doesn't have the relationship with the patient that they're prescribing for necessarily. Public Act 248 is the MAPS requirement. So I'm assuming all of you providers are now, if you are prescribing controlled substances, are registered with the MAPS system. And this does require that you do review a MAPS report prior to prescribing or dispensing a controlled substance every time. So with the consent where you just need it initially, the MAPS report must be reviewed every time you're prescribing a controlled substance. There are exceptions to this rule, so if the quantity is for less than a 3-day supply, if the medication is administered to a patient in a hospital or freestanding surgical center, as well as if you're a veterinarian, you don't have to review a MAPS report. However, even with a 3-day supply, and if they're inpatient, I would still strongly encourage a MAPS report to be viewed prior to giving the patients these medications. And the last public act I'll be covering is the limits they put on acute pain. And so if you are treating a patient for acute pain, the opioid prescriptions are limited to a 7-day supply. For this, it's really on the physician to make sure that they are the provider to appropriately write for that day's supply. The pharmacists were told to act in good judgment on if they thought it was for acute pain, but there's currently no requirement for anything on the prescription to indicate that the prescription is for acute pain. So do know that pharmacies have been advised that if they suspect that a prescription was miswritten for longer than 7 days, they are to contact the provider and request a new prescription. So be mindful of that because you could see delays in therapies for your patient if you're not adhering to the 7-day rule.
So who's defining the acute portion of it? For example, if a patient comes in and sees us and we're seeing them for the first time for their pain complaints, but they've had the problem for a month, it's not acute, or is it? Or
so that, again, it's left to the judgment of you as a provider and the pharmacist who's filling. So for me as a pharmacist, if a patient, you were getting a shorted supply because they saw a new provider that's for an example. If they've been receiving pain medications in the past, it's probably a chronic problem. I'm going to go ahead and fill it as was directed. You're going to see more issues if the patient's never been prescribed a pain medication, that it's going to flag them for being acute.
And can you write so for example, we see a new patient, it's a new onset, say, sciatica or something. Patient's getting ready to start physical therapy. We want them to have medications for the entire duration of their treatment, but do we need to bring them back every week to give them a prescription, or can we give them 4 prescriptions
Yeah. So I would have to verify. So my understanding of the law to be giving out multiple prescriptions is it has to be for the 30 days, and you can give 3 prescriptions for 90 days. I'm not sure if that would apply for the week durations. I would have to look further into the specifics in that law. With that, if you know it's going to be a longer type of pain, you are also allowed to add like a diagnosis or a reason on the prescription to give the pharmacist a better understanding of why you're filling it. And that's really, if you can provide them with more information that there is a reason they need the longer therapy, it's not likely to get denied. If you just write it without an explanation, you're at risk for the pharmacy not filling that. All right. And then just so you are aware, there are some additional draft rules going through the state legislation currently. So it's likely that these changes will be coming in the near future. So there's currently 3 draft rules. The first one is that gabapentin will become a Schedule 5 drug. This is likely going into effect early 2019. They were hoping early to have it set in October, so it would have been last month, but there was some delays and they didn't want to kind of push this out too fast with everything else that has changed this year. So right now they're anticipating February 2019 that gabapentin will start being regulated as a Schedule 5 medication. Really, this doesn't change a lot with how you're writing prescriptions, with the exception of how the quantity is written. So the only difference between a non-schedule and a Schedule 5 prescription is you do have to have the numeric quantity as well as it written out. And so you may need to have new prescriptions if that requirement is not met. But with it being a Schedule 5, it's good, valid for 1 year. You can put as many refills as you feel appropriate. So it's not going to change prescribing it that way other than that quantity.
What prompted that, out of curiosity?
So gabapentin has been used recently with heroin to help prolong the high and help prevent the down when you come off of that high. And so they've been seeing a lot of abuse in regards to the gabapentin being used as that, as well as when you take it in high doses, you can get some euphoria from it. And so a lot of other states have also been going this way, so we'll be just following suit with what I think there's probably at least 5 other states that have already scheduled gabapentin.
And nothing said about Lyrica?
Well, it's already scheduled.
Huh?
It's already scheduled.
Okay.
And so again, with it being Schedule 5, you are going to be required to do the MAPS report prior to prescribing it to at that point. Another draft rule that is likely to be accepted is required opioid and controlled substance training. This will be required for all controlled substance licensees and likely will be effective for licenses that need to be renewed after September 2019. So we're looking at another year before this is even really going to start to take effect, but will require some sort of formal education approved by the state to ensure that, again, you have the education to safely prescribe these medications. And then lastly, there'll be some updates to the bona fide prescriber-patient relationship, as I had mentioned before. Of note, as well, there was some federal legislation that got signed October 24th. A lot of this was based off policies. The only thing so far is that I've been able to read through that will really be applicable is that CMS, come 2021, will require e-prescribing of all controlled substances for Medicare patients. But again, times are changing, so we'll keep you updated as much as possible on when these rules are going to take effect. So that,
What about cannabis in the new reality?
with the recreational use,
How does that change? Because there's so much confusion about that when people are.
yeah. So from my understanding with the recreational use that was passed this week, you won't actually be able to get recreational use marijuana for at least another year.
You can't buy it, but you can grow it.
Yeah.
10 days after the election, certified.
Yeah.
So,
I actually just read an article about that. It's actually going to take about a month for that part to take effect, but I've heard that it can take up to 24 months to
for the
be able
dispensing,
to.
you
for the dispensing,
buy
you
it.
anticipating the year.
But that's what I'm saying. That now a patient comes in 2 months from now, they've got marijuana in their system, and currently the policy has been to like that's what they take, but they can't get narcotics. So now, let's say someone comes in, they're on marijuana, and narcotics are given to them. Is anyone going to be held accountable for that? Is there?
I think it really come down to your office policy and where you stand on using marijuana, because it would be the same if someone came and was, had alcohol in their system. Are you still going to prescribe them a narcotic?
I see. So it's an internal policy based on best practices.
Yeah.
But there's not a legal ramification.
Yeah, as far as I'm aware, it would be much more kind of as a provider, what you would choose to do in that situation. Before I go into how to use the MAPS reporting, does anyone have any questions about the legislation? Great. So I did want to just touch base a little bit more about the Michigan Automated Prescription System, or MAPS, just so you're aware of kind of where this information is coming from and how to best interpret these reports. So this is our prescription monitoring system in the state of Michigan. Currently, it does allow for you to pull in other states if they are using the same software system, so do be aware that you do have some access to additional information if you wanted it. But this is going to track dispensing of controlled substance, so all of the information from MAPS is coming from the pharmacy information. So if you do give a patient 3 prescriptions when they come out, they're not going to, MAPS doesn't know that they have those prescriptions out there until they go to the pharmacy and have it filled. And this is going to track your Schedule 2 through 5 drugs, so all of your controlled substances. Again, the purpose of the MAP system is to give you a tool to assess patient risk and try to prevent drug abuse and diversion at all levels being the physician, patient, and pharmacy. So as the law stated, you must be registered and create an account to be able to prescribe controlled substances. But do know that you can have a delegated user as a prescriber. And I would encourage this to make sure that you're not, again, giving out your login to have a employer staff member run the MAPS on your behalf, but to make sure they do go through the right channels to have that delegated user. And having those delegated users will link that account to your DEA number to make sure that as they go through tracking, it is linked to the correct supervisor.
Do we do that?
What, use the delegated?
I mean, do we go through that channel? Because our staff does that stuff.
Yeah, so MAPS just rolled out a new thing where they actually electronically connect with your EMR system. So
Okay.
we're in the process of doing that, so MAPS will automatically populate in your
So it'll be under the physicians, not under.
It'll be under the physicians that MAPS will be, but staff can view the MAPS because
I see.
it's documented
Within the EMR.
Yeah, we should really be on that.
I will be touching on that later, but with your EMR, when it pulls in, is that going to be something, do you guys use a patient portal, or does the patient have any access to their own chart? So that'll be something that if their MAPS report is part of their portal, it can't be viewed by the patient.
It's not.
Okay.
It comes just to the physician.
Okay, good.
But then we put it in the chart, though, don't we?
It goes in there. It has to be reviewed by the physician.
But the patients can look in their charts, though, can't they?
Only if you print it off. Yeah.
Only if you
patients
print it
only have
off.
access to the chart based on what we.
Okay.
The reason I'm kind of digging in on this is that the maps change. Like, you can do the maps for today, and then 2 weeks later do it for today, and it'll be changed because now the pharmacies have entered the actual data.
There's at least a 24-hour delay on the pharmacy
delay,
information.
So to protect the physicians, for us to print it out and say, as of X date, this is what it was, and we made our decisions appropriately, because then that data is kind of lost now. People will say, well, wait, on that day they got another medication from another doctor.
And the law is not trying to be nitpicky to that point there are limitations to the system.
Right.
And so as long as you're going off of the information that you have available to you, that's all that they're asking, that it is being reviewed.
Right.
Within the MAP system, too, there are some different reports that you can use. The most common is going to be your individual patient report, where you search the information for one specific patient. With the large office, if you do have a staff member who's helping to run these reports, you can do a bulk patient reports that allows you to input the information for all the patients that you're seeing that day and kind of put it in one folder so it's easier to look up through the system. They do also provide a prescriber report where you can, as a provider, look and see who is getting controlled substances under your DEA number. Again, that's going to help if you have any concerns about fraudulent prescriptions or any other issues with possibly inappropriate medications coming up from under your DEA number. Maybe. All right, I am frozen. Anyways, the next slide was going to go more into kind of the requirements done with the MAPS report. So as Nira said, it does need to be reviewed by the provider. And so you can have someone run the report on your behalf, but that provider needs to look at the report prior to sending that controlled substance prescription. And the patient cannot have access to their MAPS report. So you are allowed to discuss any issues on that MAPS reports that you find, but do know that you can't physically give that MAPS report to a patient within the law.
You can show it to them.
But you can't hand it to them.
No.
I would not do that. If it was me,
Yeah. That's what
I
was
wouldn't do that because, again, yeah, it states that the patient, it can only be discussed with the patient.
You know, it took me a while to understand it, so I don't know if you have a really smart patient that can look at it and kind
Yeah,
of
I would. Yeah, I would argue that.
It took me a while to kind of figure it out.
And then I was going to kind of go through and break down what the MAPS report is going to look like, again, so you can help interpret.
Should it be better for us to house it somewhere internally to view as opposed to putting it directly in the chart to avoid any type of concerns that could happen? If it had to report themselves.
If they can't, as long as they can't view it from the portal.
Right. That's as long as they don't have access to it. I think we should be safe.
Yeah,
We just have to make sure that everybody understands that.
yeah, and I think.
I just have a question to clarify the issue with the patient, have access to it. What we have now in the chart that we've been giving to patients upon request sometimes, the maps would say maps reviewed appropriate, or maps reviewed there is some violation, and we actually do list the violation in the patient chart, and we have to document the counseling that happened. So is that okay?
That is fine.
Okay.
Because that would be, again, more of like a discussion, or you had talked about that with the patient, they're aware of what violations were the MAPS report, and that is fine. It's just having that physical report so that they're not able to kind of go after the pharmacies or be able to have that information to then retaliate over everyone. How familiar do you guys feel with using the MAPS report and understanding kind of what the different risk factors are and how to look at the different tools?
Well, I felt good until you told me I couldn't show
Yeah.
it. Now I feel like I don't know anything.
Well, do you know anything about the way the score is calculated? Because it seems to be sometimes all over the
Yes.
map.
Yeah, and so with the scores, again, I have information, if I could get my slides to move forward, about that. The NARC score is a complicated algorithm. I do not know specifically how that is calculated, but the factors that go into calculating that is how many active prescriptions the patient has, how many active prescriptions across the different classes, so the narcotic, sedative, stimulant medication, how many pharmacies the patient is using, how many prescribers are providing the medication. And so those factors are all going to kind of come together to give a score to help give you just a quick visual on, do I need to look further? So the way the MAP system is set up when you view the report is it's going to give you very general information at the top, and as you scroll down into the report, we'll get more specific to kind of what's causing some of those red flags. And so when you first look, you'll see the basic patient summary, and then you'll have your NARC score, your overdose score, as well as your red flag indicators. And again, if you see your NARC score is over 350, that's a red flag that you should probably look further into the report to see why is your patient flagging that high.
350 or 450?
So the range is, I want to say like 200 to about 600 is kind of your middle range, where there could be a very valid reason of why your patient has a score within that range, but you might want to look and see if there's any potential for abuse that might be happening. If it hits over 650, that's when there's likely an issue. Yeah. And it does go anywhere from 0 to 999. Similarly with the overdose score, this is going to look more at the risk of overdose, so specifically what their dose of opioid medication would be if they're also taking a benzodiazepine. And with that score, again, if it's going to be greater than 650, you're going to start being concerned about the patient's potential for misuse and have a discussion with that patient. But also for those scores, if you do have a patient who has anywhere like above a 200 score for the overdose, you might want to consider naloxone for that patient because they are at risk of even an accidental overdose at that point.
Naloxone or decrease the dose? It was always
Up to you as a provider.
Okay. Now I have a question with the cumulative overdose dose. I've seen some reports that say the overdose score for opioids being prescribed is 500. The one for benzodiazepines for the same patient is about 400. We see the overall risk score is lower than both numbers.
Again, I do not know how they calculate that with the algorithm.
Okay.
And have to know specifically what's factored into that.
That's why it's puzzling.
It's bizarre.
I've seen
Yeah.
You've seen that too?
strange
Yeah.
numbers.
Absolutely.
And again,
I can't make
it's not going to be a
heads or tails of it.
perfect system. It's just meant to, if you see something alarming, to trigger you to further investigate what may be causing or reevaluate the patient's overall risk.
But the recommendation is over 350. Consider adding naloxone
Yeah.
to their therapeutic protocol.
And then there also are the red flag indicators that will give you a flag for, I think, multiple providers, multiple pharmacies, as well as a high dose morphine equivalent. And so it's going to flag if they're receiving, I think, more than 5 providers within a 1-year period, if they've used more than 4 pharmacies within a 90-day period, and if they've received more than 40 morphine milliequivalents daily dose or exceeds 100 morphine milliequivalents, I think, in like a 1-day period or something. Again, I can't list the specifics right off the top of my head.
To have more information on this.
Okay. And
so
those,
there is actually a max on per day and per period of time.
it's not a max, it's just an indicator that they are
Okay.
receiving high dose. And
Right,
so
yes.
it's not going to say that you need to lower the dose or anything like that, but just flagging that you are aware that they are receiving high doses.
Too much.
Because again, if you're aware of them getting, Norco 10 3 times a day, that's not going to flag as a high dose. So if they are flagging as a high dose and that's what prescribing them, they're getting opiates from somewhere else that's causing them to flag for that high dose. So again, these are all meant just to cause you to look more into the situation. With those red flags too, the MAP system isn't perfect. It's all taking information from the pharmacy, so it's only as good as the information the pharmacy is inputting. And so you will have patients that are flagging for multiple providers because the pharmacy has your name 4 different ways. And so that's automatically going to cause it to flag, even though the patient's appropriately using it.
And sometimes it's from like the same group, but
Same
just
office.
yeah,
Yeah,
same
and it's the same
and
office,
it
or you have
doesn't
a covering
recognize-
physician,
Yeah.
or if you wrote a paper prescription and they're not sure what the signature is and you have the entire group physicians listed, sometimes the pharmacy will do a best guess on who the provider is. And so it's only as good as the information that is given by the pharmacy. So again, that's why these risk indicators, the overdose scores, are specifically for further investigation into the problem, but it should not be the end-all be-all on if you're going to prescribe or not to that patient.
Would it help if we cover each other here, physicians, if one is away on a vacation, that the prescription can be signed under the specific doctor if the nurse practitioner is seeing the patient or the covering physician seeing the patient? Does it have to be the same physician who's seeing the patient that specific day?
It should be the prescription. If you're prescribing from that office that day, should be the providers who saw that patient. Again, it's not going to prevent the prescription from being filled if it's coming within the same office, but it will cause their MAPS report to look suspicious.
Prescriber situation.
And so again, as long as you guys have the policies set in your office on how to handle these situations, it's not going to kind of fall back on you. But it might cause a patient's overdose or NARC score to go high because each one of you prescribed them one prescription within the last 60 days.
So what takes one prescription?
As soon as you start adding providers, it's going to increase their NARC score.
Oh, okay.
And then it won't flag until they reach 5. But yeah, so every additional provider, so even the pharmacy, selecting, instead of like John Smith and John A. Smith, even though it's the same provider, it's going to list us 2, and that's going to drive the NARC score up. So again, it's just used as a tool to further evaluate the usage.
When you say flag, is there something on the report that shows that it's been flagged because they've had 5 providers, or
Yeah.
is that just something that gets flagged somewhere else?
No, it will flag. So when you pull up your MAPS report, under the patient summary, there's 3 boxes before you get into the prescription-specific information. So there's going to be a NARC score on the left, overdose in the middle, and then on the right are going to be red flags, or additional risk indicators, I believe is what they call them. And that is where they'll flag for multiple providers, pharmacies, or high dose. Some key things to look at too when you're evaluating a MAPS report is they do provide how the patient is paying, and that is something that I commonly use to make sure that if the patient has insurance, it should be going under insurance. And so if they're not using insurance for some reason, that can be a red flag that maybe they're not using the medication how they are supposed to if they're privately paying or cash paying for that prescription. So if any more questions or anything about MAPS, I do apologize that I'm not able to progress through the slides to get to the actual pictures of that information.
I just have a question. As a pharmacist, we've seen instances when a pharmacy will call us and refuse to fill a prescription because of concerns of overdose. When we actually sometimes see it legit, like we knew the patient, we've been treating the patient, and some of those patients are on higher doses. So where the law plays in this when the pharmacy refused to fill the prescription?
So pharmacists are allowed to refuse any prescription that they would deem inappropriate.
Okay.
And so they do have that right to refuse that prescription. I would hope that if they were able to consult with you and kind of have that discussion to feel comfortable that should resolve the issue. And so if you are having problems with that, one of the best policies is to make sure that you do have a means for pharmacies to be in contact with you to get that information to not delay therapy. But pharmacists are within the law to refuse any prescription.
I have a quick question also.
Yeah.
I also do buprenorphine for like maintenance management and opioid use disorder. Is the recommendation for that also that everybody should get naloxone? Because their scores are all
because it's a buprenorphine
right.
flagging with that. Again, it's the consideration with naloxone is if you feel that the patient's at risk of accidental overdose in general to consider using it. It's left to your professional judgment. It's not saying that if they are on this, they need naloxone. But I don't know of any specific requirements with the buprenorphine or what that recommendation is.
But there's a specific recommendation if the score is over 350 to consider.
Yes, that is from the MAP software in the state of Michigan. If their scores, that should flag you to consider naloxone, but not require naloxone. On the same basis with naloxone, do know that there is a state standing order signed by the governor that does allow pharmacies to to dispense naloxone without a prescription from a physician. So do know that even if you are not the one writing the naloxone prescription, your patient still has access to it and may still have naloxone, as long as the pharmacy is able to meet the requirements of the state to be able to dispense that.
Do you know how long naloxone is good for? Prescription.
The prescription itself would be valid for a year. The actual product itself.
The product, yeah.
So technically, from the state, they're going to put a 1-year expiration date on all prescriptions, or whenever the product itself expires, if that's less than 1 year. With that, it is good as long as it's not open until the expiration date on the product.
So we could conceivably write a script for 1 year for every patient who's above 350.
Yeah.
Okay.
With that, there's currently 3 naloxone products that are available. There's the Evzio auto-injector, which is going to be very expensive. A lot of insurances aren't covering it. The Narcan nasal spray, which is the brand, it's like I think a tier 2 or tier 3 for Blue Cross with their branded copay. And then they do have the naloxone kits, which are going to be your cheapest option. They are covered by Medicaid and Blue Cross, but that is going to come with the nuances in administration, because the naloxone kits are going to give them a vial of naloxone that either has to be drawn up to give intramuscularly or can be used intranasally. So with those kits, while it's the cheapest option and sometimes the most attainable for the patient, there is a lot of administration technique that needs to go into it and a lot of teaching. So be aware that if I was the one trying to make sure my patient had a naloxone, I would try harder for the Narcan because it's much easier to use in the event that it was an emergency and they needed to use it.
That's the nasal one.
Yeah, so and it's going to be your the cheapest of the brand options at this point. With the naloxone kit, it would be like if you have the EpiPen that's very easy to use, self-explanatory. Would be like the Narcan or the Evzio products. Giving, similar to the naloxone kit, would be like giving your patients a vial of Epi and a syringe and just hoping they can figure it out an allergic reaction. Kind of to conclude with where to go with this legislation, again, there's a lot of changes that are happening, and it's only going to become more and more changes as we get through with this opioid epidemic. The best thing that you guys can do right now is to establish what your best practices are going to be as an office and how you're going to manage how to fulfill these requirements of the law. So who is going to be responsible for making sure the MAPS reports are ran? Who's going to be making sure that the consent forms are signed? How are you going to monitor for safe, appropriate use? So again, using the MAPS reports to assess risk, but are you going to use urine drug screens? How often are you going to urine drug screen? And make sure that as an office as a whole, you guys are all on the same page on how to monitor these drugs. Again, looking at your processes for how do you initiate controlled substances, what are you going to do if you need to continue that controlled substances, and lastly, what does the policy or procedure look like if you're going to discontinue a patient off their controlled substance. Of note, with my primary care offices trying to discontinue some of these medications, we're seeing a lot of them just wanting to not deal with the laws and either send them to you guys for pain management, or just kind of cut these patients off cold turkey with their opiates. I've also had offices that are looking at patients who are on benzodiazepine and opiates and telling the patient they need to decide what's more important. Do you want to be treated for pain or anxiety? And pick one because you can't be on both anymore. Which again is probably not the most appropriate patient-centered approach to this management.
As a primary care physician, what are the current rules regarding what they can and cannot prescribe? Is there a specific quantity or dose that they can and cannot prescribe?
It's going to be the same. There's not any limitations with the exception for prescribing for substance abuse disorder. So obviously they cannot prescribe methadone or buprenorphine for substance use disorder.
So technically, if I'm a PCP, I can prescribe 3 10 milligram Norcos if I feel like it's the appropriate dose. Because of course, all of our patients are coming in and saying they are not allowed to do it anymore. Well, it's not that they're not allowed to; they just don't want.
They don't want to
Yeah.
deal with it.
Yeah.
Okay. And that is the big concern right now. Is that a lot of my offices have been telling patients that they can't do it anymore, and it's a lot of they just don't want to deal with it, even though going through these laws, I hope you feel that they weren't that bad.
No.
There's some truth in it. They cannot do it anymore the way they did it.
True.
Right.
If they want to do it now, they have to go through a lot of paperwork and staffing.
It's kind of disruptive to their workflow process.
It's not as
good for us
to them.
Yeah. You guys should be very busy.
Yeah.
So I'll make sure Deer has my contact information if you guys do have any follow-up questions or want any more assistance. Yeah.
Nurse practitioners and PAs, is there any legislation for them to be able to sign Schedule 2, Schedule 3? Is there anything in that, or is that just not?
They've changed it within the last year, and I don't know the specifics off the top of my head.
Okay.
But they have been changing legislation within the last year on the different requirements. So I believe that a lot of the restrictions on nurse practitioners have been lifted on what they're allowed to prescribe, but I would have to give you the specific documentation because I can't list it off the top of my head.
Distribute our our signatures across multiple. Well, I guess they'll be still attached to us, or maybe not.
Yeah, it would still be the supervising, but I know for nurse practitioner the C2 limitations are lifted. So again, if you have any questions, please just let me know. I'm happy for any follow-up. And then I do appreciate you guys all taking the time this morning to listen in, and I do apologize again that we weren't able to go more through the MAPS report. But Nadir does have all the slides, so you can look at the pretty pictures later. Thank you.